Can you hear me now? Can you hear me now? Okay. Okay, thanks for letting me know. So if you're joining the session for the first time, this is Dr. Shanmugapriya. I'm professor and head of the Department of Biochemistry at Government Thoothukudi Medical College, and I'm your Unacademy educator for Biochemistry. And today's session is on hyperlipoproteinemias. So I will be telling you about all 6 types of hyperlipoproteinemias. Fredrickson's classification will be discussed. I will be telling you about all clinical and biochemical features of every one of those 6 types. Okay, and this will be discussed using MCQs. And that's the plan for today's session. And before we start the session, let me tell you a few facts about Unacademy plans. Plus subscription gives you an access to both live and recorded sessions. It also gives you an access to a question bank with 25,000 plus clinical case-based MCQs. And all these MCQs are based on the latest exam pattern. And plus subscription also entails you to be a part of these comprehensive batches. We have well-structured batches for all upcoming exams. The first image is about Focus FMG 2022 comprehensive batch, which is about to begin on 19th January. The duration will be 4 months. And there is also a target NEET PG 2022 MCQ discussion batch, and that is supposed to begin. That will be initiated on 19th Jan. Duration will be 2 months. And you will also be able to participate in plus tests. So plus subscribers will be given continuously tests. There is a wide range of tests that you can apply for. Grant test, subject-wise test and system-wise tests. And this will be the schedule for NEET PG subject-wise test. And this is the schedule for FMGE subject-wise test. And I will be starting a plus course for NEET PG aspirants. It is completely MCQ based. And it is to be on, it is scheduled for 24th January. Total number of hours will be 4 hours. The first 2 hours will be between 5:30 and 7:30, and the second 2 hours will be 8 and 10 p.m. wherein I have planned to discuss all high yield MCQs for NEET PG aspirants. And I will be including all previous year questions in this course. Okay. And there is also a course for FMG aspirants, and that's again a plus course, which is starting on 26th January till 4th February. So every day there will be 4-hour session, MCQ based discussion session, wherein all topics will be covered. And these are our toppers in the latest NEET PG September 2021. The highest was 694, closely followed by 688. And these are our toppers in the latest FMG December 2021. The highest was 217 out of 300, followed by 209 out of 300. And this is the current NEET PG subscription plan that is available. But if you use any of the educators code, you get a 10% off. My code is Biochem Live. Okay, so that's all about Unacademy plans. Let's start discussing few MCQs based on hyperlipoproteinemias. So this is a very simple question. The first question, hypertriglyceridemia is seen in all except. Choice A is von Gierke's disease, choice B is alcoholism, choice C is type 2A hyperlipoproteinemia, choice D is nephrotic syndrome. Can you all try answering this? I'll be happy to see answers from your side. Von Gierke's alcoholism, type 2A hyperlipoproteinemia and nephrotic syndrome. Very good, Zul. Zul has answered it as choice C. Is there anyone else who would want to try? Pratik thinks it's choice A. Von Gierke's disease is his answer. Shweb Kadu also thinks it's choice A. Okay, Staphylococcus C. Vivek thinks it's C. Very good, Staphylococcus, Zul and Vivek. Answer is type 2A hyperlipoproteinemia. because type 2A hyperlipoproteinemia is otherwise called as familial hypercholesterolemia, where you find only an elevation of cholesterol. Yeah, in this condition you find only an elevation of cholesterol. So let's now try to learn about hyperlipoproteinemias. As I told you, Fredrickson's classification has classified hyperlipoproteinemias into 6 types. What are the 6 types? Starting from type 1. Yeah, so type 1, type 2A, 2B, 3, 4 and 5. So totally we have 6 types of hyperlipoproteinemias. And there is another way of classifying hyperlipoproteinemias for you to easily remember the clinical features and biochemical features. So for you to be able to clearly understand about hyperlipoproteinemia, I am going to help you by classifying hyperlipoproteinemias into 3 categories. The first category presents only with an elevation of cholesterol. The second category presents only with an elevation of triglyceride. And the third category will present with an elevation of both. So why do we have to classify it this way? Can anybody tell me what do we achieve by classifying it this way? Because clinical features and treatment will differ depending upon this. Because if it is hypercholesterolemia, if it's hypercholesterolemia, you know it is going to present with tendons and Thomas and accelerated atherosclerosis. So can you all quickly tell me what do you expect when there is only an elevation of cholesterol? That will be tendons and Thomas and accelerated atherosclerosis. If you are asking me what are tendons and Thomas, these are eruptive lesions which are found along the insertion of tendons. Yeah, for example, it be found along the bones, knuckles. It can be found along the knuckles, or it can be found in the ankle. Have a look at this. Yeah, these are tendons and Thomas which are present along the line of attachment of tendons found along knuckle bones, or it can be present along ankles. Yeah, along the ankle, can you see that here? So these are tendons and Thomas, and tendons and Thomas are characteristic features of what? Hypercholesterolemia. Okay, so that is going to be the feature of the first category. Whereas if it's a condition which presents with an elevation of triglyceride, then what you would observe is eruptive xanthomas. Tendon xanthomas in hypercholesterolemia, eruptive xanthomas and recurrent pancreatitis in hypertriglyceridemia. And if you are asking me why recurrent pancreatitis and hypertriglyceridemia, it is because of the lipemic serum being highly viscous. When there is elevation of TGL, the plasma will be highly viscous, and this goes and clogs small capillaries, and that causes auto-digestion of pancreas. So hypertriglyceridemias will present as recurrent pancreatitis. And if it's a hyperlipoproteinemia wherein there is an elevation of both cholesterol and TGL, you will find a mix-up of both these features. Okay, that is why I am going to classify hyperlipoproteinemias this way. Now, what are the hyperlipoproteinemias which present with an elevation of cholesterol? There is only one condition wherein there is an elevation of only cholesterol, and that is type 2A. Yeah, what is it? Type 2A. All of you, as and when I tell you, please memorize it. Please don't think I will listen to this and then later on memorize. That will never happen. So tell me which hyperlipoproteinemia presents with an elevation of only cholesterol. It is type 2A. And that is why type 2A is otherwise called as familial hypercholesterolemia. Don't you think it's a logical name? Because there is an elevation of only cholesterol in this condition, you call this condition as familial hypercholesterolemia. Okay, and it is caused by a defect of LDL receptor. It is caused by a defect of LDL receptor. So just think logically and let me know, when LDL receptor is defective, which lipoprotein will accumulate in the circulation? LDL will accumulate in the circulation, and this LDL carries cholesterol. So in this condition, there is going to be an isolated elevation of only cholesterol, and that is why the name familial hypercholesterolemia. And I also want you to remember that it is an autosomal dominant condition. So there has been so many questions on inheritance of hyperlipoproteinemias. So if you are asked what are the autosomal dominant hyperlipoproteinemias, your answer should be type 1, type 4 and type 5. So tell me what are the 3 autosomal dominant hyperlipoproteinemias? Type 1, type 4 and type 2A, type 4 and type 5. Okay. So type 2A, type 4 and type 5 are the 3 autosomal dominant hyperlipoproteinemias. Okay. So that is all about hypercholesterolemia. Now what are the hyperlipoproteinemias which present with an elevation of TGL? What are the hyperlipoproteinemias which present with an elevation of TGL? It is type 1, 4 and 5. Okay, type 1, 4 and 5. So what will you find in type 1, 4 and 5? In type 1, 4 and 5 you will find eruptive xanthomas and recurrent pancreatitis. So what are the conditions which will present with both? Tell me, what are the conditions which will present with both? Remaining. What is remaining? Type 2B and type 3. Can you all please be active in the chat box? Yeah. So what are the conditions which will present with both? Both will be type 2B and type 3. Okay. So this is about classification of hyperlipoproteinemia. So quickly, hypercholesterolemia is just type 2A. Hypercholesterolemia is just type 2A. Hypertriglyceridemia will be type 1, 4 and 5. Mixed conditions will be type 2B and type 3. Okay. So can you answer the question now? Hypertriglyceridemia is seen in all except. What will be your answer? Your answer should be type 2A hyperlipoproteinemia, because you know this condition is otherwise called as familial hypercholesterolemia, wherein there is an elevation of only cholesterol, no elevation of TGL. Okay. Now about other choices. Always whenever you work out an MCQ, try to look at other choices and try to exclude those choices as well. So von Gierke's, does von Gierke's disease present with hypertriglyceridemia? Answer is yes. Von Gierke's definitely presents with hypertriglyceridemia, because can any one of you answer in the chat box which enzyme defect causes von Gierke's? Yeah, which enzyme defect causes von Gierke's? It is glucose 6-phosphatase defect. And when glucose 6-phosphatase is defective, glucose 6-phosphate cannot be converted to glucose. So no other go, glucose 6-phosphate will get into glycolysis. When glucose 6-phosphate gets into glycolysis, what will you get as a product of glycolysis? You get pyruvate. And these pyruvate molecules will then get converted to acetyl-CoA. Yeah, pyruvate gets converted to acetyl-CoA. And this acetyl-CoA will be used for fatty acid synthesis. And whenever there is excess fatty acid synthesis, fatty acid will be stored as triacylglycerol. So all of you remember von Gierke's disease or type 1 glycogen storage disorder caused by a defect of glucose 6-phosphatase will not only present with hypoglycemia, it will also present with hypertriglyceridemia. Okay. So we know that von Gierke's will present with hypertriglyceridemia. How about alcoholism, all of you? Alcoholism is a source of anabolism, because whenever alcohol gets metabolized, the person gets high NADH. Yeah, alcohol dehydrogenase and aldehyde dehydrogenase will generate NADH, and that is why we call alcohol as a source of empty calorie. Why do we call it as a source of empty calorie? There is only energy, but there is no essential micronutrient. So excess energy will push them into anabolism, and that is why an alcoholic gains weight. And when there is anabolism, triglycerides will be synthesized. So alcoholism will present as hypertriglyceridemia. And how about nephrotic syndrome? Don't we all know that one of the biochemical features of nephrotic syndrome is hypertriglyceridemia? It is because in nephrotic syndrome there is leaky glomerulus. Yeah, glomerulus loses all small proteins like albumin. And when albumin is lost, what will happen to plasma oncotic pressure? There will be a reduction in the plasma oncotic pressure. So to maintain the plasma oncotic pressure, liver will compensate by releasing other larger proteins. And one of the larger proteins that liver releases in nephrotic syndrome is VLDL. Yeah, so please remember, in nephrotic syndrome there is excessive synthesis and release of VLDL into circulation. VLDL carries triglyceride, and that is why there is hypertriglyceridemia in nephrotic syndrome. Is that clear? So what are the causes of hypertriglyceridemias apart from familial hyperlipoproteinemias? Hypertriglyceridemia is also seen in von Gierke's disease, alcoholism and nephrotic syndrome. Okay. So the next question. So I hope you will all be able to answer this question now. Tendons and Thomas occur in. What will be your answer? Tendons and Thomas occur in. What did I tell you about tendons and Thomas? I said it's a feature of elevation of cholesterol. Right? Very good, Satyam Mishra. I am very happy. Good, Vivek. Yes. Tendons and Thomas occur in. What will be your answer? Type 2A dyslipidemia. Very good. Because I told you 1, 4 and 5. What did I tell you about 1, 4 and 5? All these three are elevation of TGL. And whenever there is an elevation of TGL, what will you find? You will find eruptive xanthomas. Yeah, you will find eruptive xanthomas, not tendons xanthomas. Very good. Now the third question is, the pathognomonic feature of type 3 hyperlipoproteinemia is. The question is, the pathognomonic feature of type 3 hyperlipoproteinemias. Can anyone answer this? This has been asked so many times as an image based question or as a factual question. What is answer? It is, can anybody answer this? It is choice B. Palmar eruptive xanthomas. Yeah, Palmar eruptive xanthomas, a pathognomonic feature of type 3 hyperlipoproteinemia. So let me tell you few facts about type 3. Very good, Swati Ilangovan. Very good, Dr. Kasturi, Vivek. Good. So let me tell you about type 3 hyperlipoproteinemia. Type 3 sounds like E, right? Type 3 sounds like E. So it is caused by a defect of ApoE. And ApoE is an apoprotein of remnant lipoproteins. Yeah, it's an apoprotein of remnant lipoproteins. So in this condition, when there is ApoE defect, remnant lipoproteins cannot be cleared off from circulation. So remnants stay back in circulation, and that is why this condition is called as a remnant disease. So tell me, what is the other name for type 3 hyperlipoproteinemia? It is called as remnant disease because remnants accumulate. And remnants carry both cholesterol and TGL. So in type 3, there will be an elevation of both cholesterol and triglyceride. It's a mixed dyslipidemia wherein there is an elevation of both cholesterol and triglycerides. And classically in type 3 hyperlipoproteinemia, you find a defect in the lipoprotein electrophoresis, which is broad beta. Yeah, the characteristic finding in lipoprotein electrophoresis of type 3 is broad beta, and that is why this condition is called as broad beta disease. It is also called as familial dysbeta lipoproteinemia. For the same reasons, also called as familial dysbeta lipoproteinemia. So tell me, what are the three names given for type 3 hyperlipoproteinemia? Can you all type it? The three names given for type 3 hyperlipoproteinemias are: number 1, remnant disease; number 2, broad beta disease; number 3, familial dysbeta lipoproteinemia. So let me tell you why you find broad beta in this condition. Yeah. So I have told you this already when we discussed a high yield MCQ in the special class. So it will be a quick revision for you all now. So generally lipoprotein electrophoresis will be done on a glass slide. I have shown a glass slide mimicking structure here. And on this glass slide, towards one end of the glass slide, you will apply the plasma, lipoprotein of which has to be separated. Okay, and this plasma has got all lipoproteins, and all your lipoproteins are negatively charged. Any plasma protein, all your plasma proteins are negatively charged. So you connect this glass slide to an electrical supply in such a way that close to the point of application is connected to a negatively charged electrode. The opposite side, ideal, is also responsible. Yes, I will tell you, Satyam Mishra, I will tell you what is happening, then you will understand it better. Okay, so close to the point of application is connected, but your answer is right, perfectly right. So close to the point of application is connected to a negatively charged electrode. The opposite side is connected to a positively charged electrode. So when you switch on the electric current, because all your lipoproteins are negatively charged, they start moving towards oppositely charged electrode. The migration gets affected by charges and by size. So what do you know about HDL, all of you? Do you all know that HDL has got the highest phospholipid content? Tell me yes or no. HDL has got the highest phospholipid content and it has got the highest protein content. And both phospholipids and proteins will give HDL the highest negative charges. So because HDL has got the highest negative charges, it will move rapidly towards oppositely charged electrode. So tell me which is the band that is present farthest from the point of application. If this is the point of application, the farthest one from the point of application, that is called as alpha band. And alpha band is nothing but HDL, because HDL has got the highest negative charges. Okay. And quite contrast to this, chylomicron. Because chylomicron size is very large, it cannot move at all. Do you understand this? Chylomicron size is the largest. So it cannot move at all. So chylomicron will be present on the point of application. So at the point of application, if you see a band, at that point of application, if you see a band, then that is because of chylomicron, if at all it is present. Why am I saying if at all it is present? Because usually you run electrophoresis of a fasting sample. Usually you run lipoprotein electrophoresis of fasting sample. And if it's fasting sample, will the sample have chylomicron? What is chylomicron, all of you? Chylomicron transports dietary triacyl glycerol. You know that, right? Chylomicron carries dietary triacyl glycerol from intestine to extrahepatic tissues. So it is dietary. If it's a fasting sample, you're not supposed to find any band at the point of application. Do you all understand this? If it's a fasting sample, you're not supposed to find any band at the point of application. But if you find a band at the point of application of a fasting sample, then you should think of lipoprotein X. What will you think of? Lipoprotein X. Can anybody think and tell me what is lipoprotein X? In which condition will you find lipoprotein X? Have you heard of this term lipoprotein X before? You must have, right? Lipoprotein X is a feature of LCAT deficiency. All of you look at the slide. Lipoprotein X is very good, Vivek. Yes. Lipoprotein X is a feature of LCAT deficiency. What is LCAT, all of you? LCAT is nothing but lecithin cholesterol acyl transferase. LCAT is nothing but lecithin cholesterol. Very good, Satyam Mishra. You're also right. So LCAT deficiency, LCAT is nothing but lecithin cholesterol acyl transferase, and the main function of LCAT is to convert discoidal HDL to spheroidal HDL. So whenever you are asked, you should be able to answer this. If you are asked what is the function of LCAT, what will be your answer? It is to convert discoidal HDL to spheroidal HDL. So whenever there is LCAT deficiency, which HDL will accumulate? Discoidal HDL accumulates. And this discoidal HDL will take up the shape of lipoprotein X. And lipoprotein X is also a feature of, as Satyam Mishra has mentioned, it is also a feature of obstructive jaundice or cholestasis. Because whenever there is obstruction in the bile duct, whenever there is obstruction in the bile duct, bile salts will overflow into circulation. And these bile salts are amphipathic lipids. So these amphipathic lipids will take up a discoidal shape. So tell me, what are the conditions wherein lipoprotein X is observed? This has been asked at least 3 times in NEET PG. Lipoprotein X is a feature of LCAT deficiency. It is also a feature of cholestasis or obstructive jaundice. In LCAT deficiency, the discoidal HDL takes up the shape of lipoprotein X. In cholestasis, bile salts, because they are amphipathic lipids, they will take up a discoidal shape. Okay. So that in that case, you will find a band at the point of application. And after lipoprotein X or after the point of application, the first band would be beta band. And this beta band has got, yes, you're right, Zul. Your answer is right. So next to this, there is a beta band, and beta band has got LDL. Okay, and after beta band you call it as pre-beta band. Why do you call it as pre-beta band? Because it has migrated faster than beta. So you call this as pre-beta band, which will have VLDL. So tell me, if it's a fasting sample, what are the three bands that you will see? The band that is farthest from the point of application is alpha band, which is made up of HDL. After alpha band, it is pre-beta band, which is made up of VLDL. After pre-beta band, it is beta band, which is made up of LDL. Okay, and where will you find remnants? Remnants like intermediate density lipoprotein. Not only intermediate density lipoprotein, all remnants will move here. Do you see a grey color band that I've shown here? Yeah, I have given grey color just to differentiate it. So this grey band is the region where you expect remnants. And usually in circulation, if it's your sample or my sample, we would not have enough remnants to be seen as a band. But if it's a remnant disease patient, yeah, what is remnant disease? I told you, in type 3 hyperlipoproteinemia, wherein remnant concentration increases, you will find a broad beta. Do you understand this? Because remnant band and the beta band will coalesce to form a broad band. You call it as broad beta, and that is why this condition is called as broad beta disease. Is that clear? So what are the facts I've told you about type 3 hyperlipoproteinemia? Can you all quickly tell me? 3 sounds like E. So type 3 hyperlipoproteinemia is caused by a defect of ApoE, and ApoE is a remnant apoprotein. So you call this condition as remnant disease. Because remnants carry both cholesterol and triglyceride, you will find it as a condition wherein there is an elevation of both cholesterol and TGL. In type 3, you find a characteristic broad beta on lipoprotein electrophoresis. That is why you call this condition as broad beta disease. It's also called as familial dysbeta lipoproteinemia. And to complete the discussion, the normal ApoE allele that you and I have would be E3. So which is the normal allele that is present? It is E3 allele. And instead of E3, if you find a homozygous E2, then that will result in type 3 hyperlipoproteinemia. And there is a pathognomonic condition of type 3 hyperlipoproteinemia, which is palmar eruptive xanthomas. Do you see that here? Yeah, do you see eruptive lesions here? So these are palmar eruptive xanthomas. So xanthomas can be found anywhere, but if you find eruptive xanthomas on the palm, it is pathognomonic of type 3 hyperlipoproteinemia. There is another feature of type 3 hyperlipoproteinemia, which is xanthoma palmaris striae. What is xanthoma palmaris striae? This has been asked once. Yeah, yellowish or orangish discoloration along the palmar creases. Yeah, what do you call this condition as? You call this condition as xanthoma palmaris striae. So these two are the features, are pathognomonic features of type 3 hyperlipoproteinemia. Is that clear, all of you? Yeah, so what is the answer for this? The pathognomonic feature of type 3 hyperlipoproteinemia is, yeah, both are the same, choice B or choice C. Okay, palmar eruptive xanthomas. Now the next question, read this question carefully and give me the answer. It's an interesting question. A 15-year-old child presents with repeated episodes of pancreatitis. Yeah, if it's pancreatitis, what will you suspect? Elevation of TGL. Serum triglyceride concentration is 1100 milligram per deciliter. What is a normal triglyceride concentration? Normal triglyceride concentration is less than 150 milligram per deciliter. So in this case, there is an elevation. Cholesterol is 250, which is close to normal. Yeah, normal cholesterol is less than 200 milligram per deciliter. So it is close to normal. So it's a case of isolated elevation of TGL presenting with recurrent episodes of pancreatitis. And lipoprotein lipase enzyme activity is low. The diagnosis is, can anybody give me the answer? Very good, Satyam Mishra. Satyam Mishra has given the right answer. He has given it as choice A. But can you all tell me, just by looking at this case, which is an elevation of only TGL, what are the two causes that you can exclude? Very good, Vivek. If it's an isolated elevation of TGL, what are the two causes that you can exclude? Can you all give me the answer? You can exclude type 2A hyperlipoproteinemia, because we know for sure this is familial hypercholesterolemia, wherein cholesterol level would have been elevated so high. Okay, and you can also exclude choice C, type 3 hyperlipoproteinemia. Just now I told you in detail about type 3 hyperlipoproteinemia. I said in this condition there will be an elevation of both cholesterol and TGL. So just by looking at the serum lipid profile, wherein there is an isolated elevation of TGL, I have excluded choice B and choice C, and I am left with choice A and choice D. And because they have mentioned that lipoprotein lipase activity is low, because they mentioned that lipoprotein lipase activity is low, as Satyam Mishra and Vivek have answered it, I would go for choice A, which is type 1 hyperlipoproteinemia. So what is type 1 hyperlipoproteinemia? It is otherwise called as familial chylomicronemia syndrome. All of you memorize it. Type 1 is otherwise called as familial chylomicronemia syndrome, and it is caused by a defect of either ApoC2 or lipoprotein lipase. It is caused by a defect of either ApoC2 or lipoprotein lipase, because had you attended my special class on lipoprotein, I would have told you that chylomicron metabolism is initiated by ApoC2 activating lipoprotein lipase. Lipoprotein lipase, I've told you, will be clinging to the vessel wall, held in place by heparin sulfate. So only after ApoC2 activates lipoprotein lipase, chylomicron metabolism can be initiated. So all of you tell me, what do you expect when there is a defect of either ApoC2 or of lipoprotein lipase? Which metabolism will be affected? Chylomicron clearance will be affected. So chylomicron stays back in circulation, and that is why the name familial chylomicronemia syndrome. So what have you memorized about type 1 hyperlipoproteinemia? Type 1 is called as familial chylomicronemia syndrome. It is caused by a defect of either ApoC2 or lipoprotein lipase. And in this condition, chylomicron level is elevated, and because chylomicron carries triacylglycerol alone, there will be an isolated elevation of triglyceride in this condition. And whenever there is an isolated elevation of TGL, what are the clinical features that you expect? Can you all type it in the chat box? If there is an isolated elevation of TGL, what are the clinical features you expect? There is going to be eruptive xanthomas and recurrent pancreatitis. Eruptive xanthomas and recurrent pancreatitis. So if you see a child presenting with eruptive xanthoma and recurrent pancreatitis, and you see that there is an isolated elevation of TGL, to make a diagnosis, milky white plasma, to make a diagnosis of type 1 hyperlipoproteinemia, which enzyme activity should be checked? All of you? Which enzyme activity should be checked? I have given it in the slide. Which enzyme activity? Lipoprotein lipase enzyme activity should be checked, and that will be low in this patient. Okay, but to check for lipoprotein lipase activity, what sample will you ask for? To check for lipoprotein lipase enzyme activity, what sample will you ask for? If you don't mention that you want post-heparinized blood sample. What is the blood sample that you will ask for to show that lipoprotein lipase enzyme activity is low? It has to be post-heparinized blood sample. What do you mean by post-heparinized blood sample? You inject heparin into the person and then collect the blood sample and then allow plasma to get separated. In that plasma, you should look for lipoprotein lipase activity. That is what we mean by post-heparinized blood sample. So if you're asking me why post-heparinized blood sample, because just now I told you, look at the image here. Just now I told you heparin sulfate proteoglycan is present along the vessel wall and it will be holding the lipoprotein lipase enzyme. So if you just like that collect the blood sample cannot act as a source of lipoprotein lipase because lipoprotein lipase is clinging to the vessel wall. So what should you do? You should inject heparin. Can you see that here? Once you inject heparin, heparin will compete with heparin sulfate to hold the enzyme. So lipoprotein lipase will detach from the vessel wall, then it gets into circulation, and that plasma can act as a source of lipoprotein lipase. And in that plasma you should show that lipoprotein lipase enzyme activity is low. Yeah, so that is how you make a diagnosis of type 1 hyperlipoproteinemia. So can we quickly recap all that we have learnt about type 1 hyperlipoproteinemia? What is type 1 hyperlipoproteinemia, otherwise called as? It is called as familial chylomicronemia syndrome, caused by a defect of either ApoC2 or lipoprotein lipase. Chylomicron carries triglyceride alone. So in this condition there is an isolated elevation of only TGL. And because there is an isolated elevation of TGL, clinical features will be eruptive xanthomas and recurrent pancreatitis. And to prove your diagnosis of type 1 hyperlipoproteinemia, you should show that plasma lipoprotein lipase activity is low. For which, what is the blood sample that you should ask for? You should ask for post-heparinized blood sample. Okay. So what is answer, all of you? The answer here is type 1 hyperlipoproteinemia. Okay. The most common hyperlipoproteinemia is, can you all make a guess? There are 4 choices, type 1, 2A, 4 and 3. Which is the most common hyperlipoproteinemia? It is type 4. Yeah, the most common hyperlipoproteinemia is type 4. Have we learnt about type 1? Just now I told you about type 1 in detail, right? So we have learnt about type 1, we have learnt about type 2A, we have learnt about type 3. So let me tell you about type 4 and type 5. Yeah, let me tell you about type 4 and type 5. Both type 4 and type 5, they are called as familial hypertriglyceridemias. Yeah, both type 4 and type 5, they are called as familial hypertriglyceridemias. And they are autosomal dominant conditions. Didn't I tell you what are the 3 autosomal dominant conditions I told you? Type 2A, type 4 and type 5. Yeah, type 2A, type 4 and type 5 are autosomal dominant conditions. And in this condition, there is an unknown etiological, yeah, the basic pathology is not known, but there is unknown etiological increase in the rate of VLDL synthesis and decrease in the rate of VLDL catabolism. Do you all understand this? There is an increase in the rate of VLDL synthesis and a decrease in the rate of VLDL catabolism. So in either case, what will accumulate? VLDL will accumulate, and VLDL carries endogenous triacylglycerol. So that will be an elevation of TGL. Yeah, that will be an elevation of TGL. And that is why, what did I tell you? Type 4 and type 5. Yeah, all of you remember, type 4 and type 5 are called as familial hypertriglyceridemias. They are autosomal dominant condition. There is unknown etiological increase in the rate of VLDL synthesis and decrease in the rate of VLDL catabolism. So VLDL accumulates, that is why there is an elevation of TGL. And if you are asking me, then what is the discrimination between type 4 and type 5? In type 4, there is only the congenital defect. There is only the primary defect of lipoprotein metabolism. Whereas in type 5, the congenital defect is associated with secondary causes of hypertriglyceridemias. So can you give me few secondary causes of hypertriglyceridemia? Obesity. Yeah, one cause can be obesity. Or alcoholism, if a type 4 person is alcoholic. Or a person on oral contraceptive pills. Or von Gierke's disease. Yeah, or it can be nephrotic syndrome. So a type 4 person, yeah, type 4 person which is just primary hyperlipoproteinemia, if a type 4 person presents with secondary causes of hypertriglyceridemias like an obese person, a chronic alcoholic or a person on oral contraceptive pill, then the presentation will be severe. And when the presentation is severe, we call it as type 5. Is that clear? That is all because initially we thought both are 2 different entities. Now we have understood that severe form of type 4 is type 5. Okay, so what are the three autosomal dominant hyperlipoproteinemias I told you? Type 2A, type 4 and type 5. Okay. So now you know the answer. Can you all give me the answer for this question? All of the following are autosomal dominant except. Yeah, all of the following are autosomal dominant except your answer should be type 1. What did I tell you about type 1? It is familial chylomicronemia syndrome. It is autosomal recessive. Very good Vivek, very good coffee doctor, very good Dr. Kasturi, very good Swati. Okay, so can we summarize? So with this we are done with the MCQs. I will quickly take 5 minutes to summarize all that we have learned so far. So hyperlipoproteinemias are classified as those which present with hypercholesterolemia, those which present with hypertriglyceridemia and those which present with both. And can you all tell me which condition presents with hypercholesterolemia now quickly? Hypercholesterolemia is type 2A. Yeah, and quickly recap all that I've told you about type 2A. You call it as familial hypercholesterolemia. It is caused by a defect of LDL receptor. Yeah, it is caused by a defect of LDL receptor. Now, what are the conditions which present as hypertriglyceridemia alone? Hypertriglyceridemia alone will be type 1, 4 and 5. Yeah, type 1, 4 and 5. And what is type 1? I told you type 1 is familial chylomicronemia syndrome caused by a defect of either ApoC2 or lipoprotein lipase. Yeah, it is caused by a defect of ApoC2 or lipoprotein lipase. And type 4 and type 5. What did I tell you about type 4 and type 5? They are autosomal dominant conditions. They are called as familial hypertriglyceridemia, wherein there is an unknown etiological increase in the rate of VLDL synthesis and decrease in the rate of VLDL catabolism. Okay. And what are the conditions which are mixed? What are the conditions which are mixed? It is type 2B and type 3. And we have already learnt about type 3 in detail, right? What did I tell you about type 3? Yeah, type 3 is ApoE defect. It is remnant disease. I told you, right? Type 3 is ApoE defect. It is remnant disease. And in this case, we also call it as familial dysbeta lipoproteinemia. It is also called as broad beta disease. Okay. Now, there is only one condition about which I am yet to tell you. Yeah, what is that condition we have not discussed about? It is type 2B. So, type 2B is otherwise called as familial combined hyperlipidemia. Yeah, what do we call it as? FCHL. What is FCHL? Familial combined hyperlipidemia. Combined because there is an elevation of both cholesterol and TGL. Okay, that is why it is familial combined hyperlipidemia. And in this condition, there are two defects. One is increase in the rate of VLDL synthesis. Second one is small LDL particle. So tell me, what are the two defects in familial combined hyperlipidemia? One is increase in the rate of VLDL synthesis. The other one is small LDL particles. So all of you tell me, what do you expect when there is increase in VLDL synthesis? There will be an elevation of TGL. What if there is small LDL particle? Will you all agree with me if I say if the LDL particle size is smaller, number will be more? Yes or no? If the LDL particle size is smaller, number will be more. Yes or no? For a given cholesterol, if the size is smaller, number is going to be more. And when the number is more, the rate of clearance of LDL from the circulation will be reduced. So LDL clearance is affected. So LDL concentration in the circulation increases. When LDL concentration in the circulation increases, that increases cholesterol level. And that is why you find an elevation of both TGL and cholesterol in familial combined hyperlipidemia. Okay, so that is all about the 6 types of hyperlipoproteinemias. And apart from these 6 types of hyperlipoproteinemias, I also told you about LCAT deficiency. Remember? Yeah, I also told you about LCAT deficiency. And LCAT deficiency can be of 2 types. One is partial LCAT deficiency. The other one is complete LCAT deficiency. Partial LCAT deficiency will cause fish eye disease. Yeah, partial LCAT deficiency will cause fish eye disease, because as I told you, when there is LCAT deficiency, HDL formation is affected. And you all know that HDL is involved in reverse cholesterol transport, wherein HDL collects cholesterol ester and phospholipids from extrahepatic tissue membranes and it reaches the liver. And when there is a defect of reverse cholesterol transport in all extrahepatic tissue membranes, cholesterol ester accumulates. When cholesterol ester accumulates in cornea, that causes haziness of cornea, and that is why it is called as fish eye disease. Complete LCAT deficiency will present as hemolytic anemia and chronic kidney disease. Yeah, complete LCAT deficiency will present as hemolytic anemia and chronic kidney disease. And in lipoprotein electrophoresis, what will you find in LCAT deficiency? You will find lipoprotein X. Okay, so that is all about hyperlipoproteinemias. Do you have any more doubts? So with this, today's session is over. So all of you take time to memorize all these facts and try to work out as many MCQs as possible as far as this topic is concerned, because this is a high yield topic wherein many questions have been asked either in biochemistry or in medicine. Okay, so my best wishes. Thank you. See you all sometime soon with another session. I will be taking another session on recombinant DNA technology. Okay.